Hello everyone, and a warm welcome to this webinar on building community literacy around vaccines and vaccine development experiences from KEMRI-Wellcome. This webinar is a part of a series of brand webinars with the goal of providing information on available career options in the field of vaccinology. My name is Clive Nyaribo, Assistant Research Officer at KEMRI-Wellcome Trust Research Program, providing support to the vaccine workforce development program together with my colleagues, Professor George Warima, Marian Munena, and Renee Imbai. We welcome you to this session. Before we get started, a few housekeeping matters. Kindly note that this webinar is being recorded. Kindly feel free to use the chat option to share your questions during the presentation, and we'll address them during the Q&A session. We'll have a few open slots for people to directly ask questions to the presenter. If your internet is stable, you can raise your hand using the available icon. As Arya mentioned, this is a series of brand webinars with the goal of providing information on available career options in the field of vaccinology. This being run under the KEMRI-Wellcome Trust Research Program, which is a well-known health research unit of excellence based in Kilifi and Nairobi in Kenya, as well as Mbare in Uganda. Over the years, we have excelled in the use of novel ideas and collaborations to achieve better health for Africa, while also developing African scientists, scientific leaders. Our vision of the program is to undertake cutting-edge and novel research relevant to national, regional, and global needs. It's under this program that we have the Vaccinology Workforce Development Program that aims to expand the technical know-how and capability for sustainable end-to-end vaccine research and development in Africa through training and knowledge exchange activities in the vaccine ecosystem. This involves areas such as target product profiling, research and discovery, preclinical and clinical studies, biomanufacturing, regulatory affairs, and ethics and deployment. The workforce development is through three channels: internships at human vaccine manufacturing institutions that aim at establishing a mentorship scheme that links interns with senior vaccinologists and healthy market systems and engagement academics globally to share, strengthen the research experiences in vaccine research and development and manufacture and enhance career development. Two, there is a full funded master's level course in vaccinology where applicants are selected based on their direct involvement in vaccine research, their professional excellence, and academic achievements. And three, we have webinars like what we have today to hire career scientists, graduate and undergraduate university students in Africa to provide information on possible career options for university students, including career decision making. This program is in alignment with the Africa's Union's platform for harmonized African health products manufacturing, ambition to increase local vaccine production to meet 60% of Africa's routine immunization needs by 2040, and strengthen the capability for vaccine research, discovery, and manufacturing in Africa. And this webinar series is part of this engagement. Today, we are glad to have our speaker, Noni Mumba, who will be discussing building community literacy around vaccines and vaccine development experiences from KEMRI-Wellcome. Noni is the head of engagement at KEMRI-Wellcome. Noni Mumba is an engagement practitioner with over 10 years of experience in community and public engagement for global health research in low and middle income country settings. This expertise also includes engaging with broader and specific topics of interest, including local, national, and international global health research stakeholders, including funders. Her role at KEMRI-Wellcome Trust Research Program includes development of engagement strategies and innovative approaches for the engagement and environment of host communities, stakeholders, and policymakers in research planning, conduct, and uptake of findings into policy. She also oversees mentoring, evaluation, and learning of engagement activities. Prior to KEMRI-Wellcome Trust Research Program, Noni has another 10 years of experience in health promotion and strategic health communication with non-governmental health organizations across Kenya. Noni is involved in building capacity of KEMRI-Wellcome Trust Research Program engagement staff, as well as researchers on engagement. In the last 5 years, this capacity strengthening has extended beyond KEMRI-Wellcome Trust Research Program through webinars, teaching engagements. For example, the University of Oxford's postgraduate diploma in global health research, community engagement module, and collaborative research projects. She has participated in the development of community engagement learning tools and courses, including the online community engagement course on MESH. This is an online community engagement community of practice, COP platform, and the WHO Toolbox for COVID-19 clinical trials, among many others. She is a member of the Global Healthy Bioethics Network, the National Institute of Health and Care Research, NIHR's Community Engagement and Involvement Advisory Network, and has co-authored several publications on community engagement and ethics. She has also been a long-standing member of the National Institute of Health and Research funding committees, specifically healthy policy and research and systems research. Previously, she was a member of the Ethics Advisory Board for Target Malaria, a consortium looking for malaria solutions through mosquito gene editing. She holds a Master of Arts degree in Development Communication. Over to you, Noni.
Hi, everyone, and thank you so much, Clive, first of all, for the invitation. I think the last time I did a vaccinology cause talking was perhaps in 2023, if I can remember. So I'm really excited to be back again, although that was a physical one. This one is a webinar, but notwithstanding, it's still a real pleasure to meet with you all and give this talk on how we can engage with our communities and the populations that are targeted for vaccines, and ensure that they have a good understanding of what vaccines are all about, how they're developed, and be able to take up those vaccines from a point of information, a point of understanding. So I really appreciate, and I'll move on to share my presentation. So just give me 1 second. Sound. So Clive, you will let me know once my slides are up and presenter mode.
Yes, we are able to see the slides.
All right, thank you so much. So my talk this morning, it is morning Kenyan time. I don't know what time it is where you're joining from, but on our end it is still morning. So my talk this morning really is around engaging communities or the broader population on vaccines, including vaccine development. I'm going to base my talk on our experience here at the KEMRI-Wellcome Trust Research Program. And you may or you may not know, we are not necessarily a manufacturing organization, vaccine manufacturing organization. We are a health research organization. So we carry out health research, which includes conducting vaccine trials. So the experience that I'm going to share is more linked to carrying out vaccine trials as opposed to vaccine manufacturing. But the learnings are learnings that can be used across different areas along the entire vaccine ecosystem. Just to start off, I'll give a bit of a background. So as I've said, I'll base my talk on the KEMRI-Wellcome Trust Research Program. So I'll take you through a bit of a contextual background around vaccines and some of the issues surrounding vaccines. And then I'll talk about the KEMRI-Wellcome program and our engagement platform. And then I'll finalize with some of the things that we've done for how we have supported vaccine trials, which is experiences and learnings that can be, as I've said, used in other areas of the entire vaccine ecosystem. So we all know, and I think there've been speakers perhaps in the past that have really been able to bring out the fact that vaccines have been successful. They continue to be successful in reducing disease incidence, infections, and in some instances, vaccines have contributed to completely eradicating some infectious diseases. However, while this is known, there is still a lot of mistrust and a lot of hesitancy, especially amongst the same population that is intended for these vaccines. The same group of people that are the target for the vaccines, there is still quite a lot of mistrust and hesitancy amongst that populations, and not only just in our setting, for example, in low and middle income countries or in Africa, for example, but across the globe, hesitancy and mistrust on vaccines is still existing, and in some instances, maybe we could say that it might have increased, especially after the COVID-19 pandemic. Aside from mistrust and hesitancy, which community engagement can attempt to address, there are other more systemic issues that affect vaccine uptake amongst populations, and a lot of these are around health system challenges related to availability of vaccines. And you'll see this a little bit later. I'll talk about it in one of the bullet points, as well as access, even when vaccines are available in country, are the most vulnerable, for example, or those that are intended to get those vaccines, are they able to access them? Are the vaccines being stored in a manner that then is useful for use, or will be able to be efficacious when they are actually given to the people that they are intended to be given to? So those are things that community engagement may not necessarily address, but it's important for people who are planning or carrying out community engagement activities for vaccines to have that at the back of their minds, to be able to actually capture or be able to link up with partners in the health systems to ensure that when community engagement, when the demand is being built, or when we are talking with community members or the public to take up vaccines, then there are appropriate health systems to be able to ensure that people have access. And so community engagement, really, given that background, especially related to mistrust and hesitancy, can strengthen the trust in vaccines and potentially enhance the uptake of vaccines by the population. So what are some of these things that are causing mistrust, are causing hesitancy? Some of the concerns around vaccines and around the development of vaccines stem from where vaccines come from. So these articles here are attempting to put in a case for why there is need for investing in vaccine development within the continent and testing of those vaccines within the continent. There have been concerns about vaccines being developed elsewhere and then being brought into the continent to basically do what is called testing, or use Africans as commonly out there in the lay language, use Africans as guinea pigs. So those are real concerns related to vaccines, and anybody who wants to get into the area of vaccines and vaccine development needs to be very aware of those kinds of concerns. I think the question still remains, though, that even when we develop vaccines in Africa within our own setting, are those vaccines going to be taken up? Is that going to eradicate the mistrust on vaccines? And we'll continue talking about that as we go on with the presentation. So this is an example of the area of mistrust and what I've just talked about in terms of Africans being used as guinea pigs, or the African continent being used as guinea pigs. Those perceptions are there, they exist, and this particular quote drawn from a paper or an article that was talking about the failed Ebola vaccine trials in Ghana in 2014 really just brings out some of the issues around vaccines, vaccine development, conducting vaccine trials, and eventually the uptake of vaccines that have been licensed. So, for example, this particular quote from one of the researchers, was sharing about what happened in Ghana, and they said community members, health workers, and regulatory institutions quickly developed concerns about the intent, the procedures, origins of the proposed trials. They did not trust its safety and thus had reservations about participating in the trials. This impaired the network of relationships required for the effective conduct of the trials and eventually led to their cancellation. So this particular article was sharing that in Ghana, the vaccine trial for Ebola was cancelled. And you can see here the level of mistrust goes all the way. It starts with the community, healthcare workers, regulatory institutions. So it's not only just with community members, it's across board. And we may have experienced that even during COVID, that in some situations, even healthcare workers, including even doctors, were refusing COVID-19 vaccines and were, prompting or, encouraging also people around them in their workstations, in their homes, in their areas where, they have some sphere of influence, were encouraging people not to take up the COVID-19 vaccines. So some of these concerns and mistrust on vaccines, especially vaccines that are perceived to have come from high-income countries, more economically powerful countries. Some of the concerns are around the perceived historical or influence that came with the colonization, or the fact that high-income countries still have power and influence over health research, and low-income countries in our settings don't have a lot of say in terms of what is brought into the continent or into the country. And so those are still perceptions that continue on to date, and they actually do harm in terms of vaccine trials and uptake of vaccines at the moment. I've already talked about, the populations in Africa seeing themselves as guinea pigs, leaders, thinking and feeling, that their populations, their people are being used by the so-called, whites, more powerful countries as guinea pigs. And this really was increased during the COVID-19. This type of thinking was increased during the COVID-19 pandemic because of some of the media or some of the clips that were being shown on media, and I'm sure a lot of us may be familiar with the two French doctors that those are clips that went viral during the COVID-19 pandemic, just when vaccines were going to be rolled out and trials were being conducted, who are purported to have said that they were going to use Africans as guinea pigs. And so that caused a lot of an uproar. So that is one thing. And the other issue also that is around lack of trust, especially around clinical trials for vaccines, is the issue of access. Again, during the COVID-19 pandemic, we saw that, yes, African countries participated in the clinical trials for the vaccines, but when it came to access, that was a problem. When the vaccines were licensed, the high-income countries went ahead to secure a lot of vaccines for their own populations, and the African continent had to almost literally, beg around for these vaccines. So a lot of this has really fueled suspicion, mistrust, fear that then has also fueled rumors around vaccines and how vaccines are developed and deployed. So what is the answer? I'm sure we are in this webinar and we've been following, perhaps those that have been following the Vaccinology series. You know, the idea is to enable the African continent to be able to manufacture its own vaccines. However, the question still remains, yes, vaccines can be manufactured in the continent, and we do already have some countries that are manufacturing vaccines. Some countries, according to this article by PATH, and other partners, the Africa CDC and WHO, who are looking or conducting an analysis on the manufacturing arena in Africa. And, you know, that analysis was able to show that there are countries that are already manufacturing. They've already signed technology transfer agreements. Other countries are able to manufacture, but they are still in the process of signing technology transfer. So there is already a sense of or there is already manufacturing happening within the continent. And the idea is to increase this and potentially even develop right from the basic research developed from Africa vaccines within the continent. One of the key issues has been, yes, vaccines will be manufactured in the continent, but will the African continent buy from the continent, or will they still be buying from the high-income countries? And in May of 2024, health ministers from African countries signed an agreement that they actually were committing to buying vaccines that would be manufactured in Africa. So I've put down there sort of like something to really think about. So the demand will be there. African countries are committing to buy. However, while the demand for the manufacturers might be there in terms of ministries purchasing, the uptake is something that really needs to be thought about. So countries can buy. Kenya, for example, can purchase the vaccines that have been manufactured within the continent, but it is not equal to populations taking up those vaccines. There's still some work that needs to be done to ensure that populations also trust the vaccines that are coming from within our own continent. So I'll move on now to share, sorry. So in terms of the demand, I'll give an example of a case in this country, Southern Sudan, I think that's the way it's pronounced, that had an outbreak, and vaccines, you know, a vaccine was rolled out. However, the population refused to take up that vaccine, and the disease continued to spread. And this really was caused by mistrust, deep-seated mistrust of the central government. So I'm really highlighting the fact that even though vaccines can be developed within the continent, if the population still has mistrust of its own government, maybe the departments of health, it will still be an uphill task to have those communities take up those vaccines. And so community engagement using different channels can actually help to build up that trust. But as you'll see in my presentation, this community engagement requires investing heavily. It requires very good and very well-planned communication and engagement. And because it takes time, it also requires quite a bit of sacrifice. So I'll move on now to just talk about our research program, and especially focusing on the engagement, and then I'll wrap it up towards the tail end of the presentation with how then do we, or what kind of engagement have we done, and I'll finish with a short 8-minute video. So apologies if you have already seen this. I'm just sharing it so that I can just contextualize my talk. So we are a health research organization, as I've said, Health Research Institute, a collaborative program between the Kenya Medical Research Institute, Wellcome, and the University of Oxford. We were established in 1989. We have 3 hubs, as can be seen on the map of Kenya and Uganda. We have a hub on the coast of Kenya in Kilifi, in Nairobi, in the capital city, and in eastern Uganda, in Mbale. We are about 800 staff. In Kilifi, we have a large health and demographic surveillance system of over 250,000 people in terms of the population. And as a research institute, we carry out diverse research projects that feed directly into policy and healthcare services. So this is just a pictorial of what I've just shown on the map. The Kilifi, which is towards, it's on the north of Mombasa, for those who may be familiar with Mombasa in Kenya. Carry out clinical trials, surveillance studies, social science and health systems, and we have a large biobank. And most of our engagement is with the rural population, and then the local Department of Health, as well as schools and young people and the media. And then Nairobi, as I had shown on the map, the capital city, we also carry out clinical research work in some of the hospitals within Nairobi. And then a lot of our health systems and policy research work is actually done within our Nairobi office, as well as other research that is more regional and international facing. So our engagement audience in Nairobi is mostly policymakers. And then Mbale is a peri-urban site, also carrying out a lot of clinical research work in 2 large hospitals in Mbale and in Soroti. The engagement population is community members as well as local ministries of health. So we have undertaken some vaccine work at our research program. There are actually some vaccine trials that have started now, like RVF, that is not on the list here, but we've carried out malaria vaccine trials, Ebola, Shigella, and we also undertook COVID-19 vaccine trials. And these clinical trials, or these vaccine trials, including all other research work within our research program, is supported by a lab platform, a surveillance platform, clinical services platform, and then the platform that I head, which is the community, public and policy engagement platform. So this platform within our research program is organized into 3 broad areas that are interconnected. That's the arrow that is running across all the 3 broad areas. One of the areas is engaging with local communities and stakeholders in the specific sites where we draw research participants from. And we use various approaches that I'll show in a later slide. We also engage, so that we call that community and stakeholder engagement. The second broad area we refer to as public engagement, where we engage with publics of specific interest, like school students and university students, as well as the media, and then the general population, which we call just the broader public. And then the third arm is policymakers, as well as policy implementers, and we call that policy engagement. So these are the 3 main arms of our engagement, where we use different approaches to be able to build relationships and then engage at the start of studies, while the studies are being conducted, and at the close of research studies. So these are some of the approaches that we use for engaging. And even when we are conducting engagement activities on vaccines, these are some of the approaches. So we have a community advisory board that we engage whenever we want to, start a research study. So if we have a vaccine trial, we will engage the community advisory board. We will also work with the community advisory board and local leaders like chiefs to reach the broader population through large community meetings. We have a schools engagement program where we are also encouraging young people to take an interest in science, including vaccines and vaccine development. I've talked about policymakers, so we also engage with policymakers. And we did, for example, during the COVID-19 vaccine trials, we did a lot of engagement with the Ministry of Health, both at the national level and at the local level. Very important stakeholders because they determine the vaccines that go out to the population and they approve them as well. Then for the broader public, like the general population, we have a radio program that has been running since 2016. And we have used this radio program to engage the broader population around vaccines, how vaccines are made, and vaccine trials that are conducted within our setting. So that is a short, sort of like a snapshot of our engagement platform and our program. So I'll move on now to talk about how we have our experience of engaging the population and especially communities that we draw on to participate in our vaccine trials. So that's what I'll move on to speak about in the next couple of slides. So when you think about vaccines, obviously, as we are implementing our engagement, the starting point always is where have the vaccines come from. And so it is important to think about, the different phases of vaccine development, because when you are engaging the population, that needs to be clear to the community that you are engaging. So we actually use drawings or pictures or diagrams to be able to explain either a drug development or a vaccine development process, right from the lab where the effective agent is identified, preclinical trials in animal models, and then initial phase 1 trials all the way through to phase 2 and phase 3, and subsequently after that, other phases where a licensed vaccine is being observed as it is now being distributed in the population. So this process is important because at the point at which you are recruiting community members or volunteers into your vaccine trial, and obviously subsequently when that vaccine is being distributed in the population, it's important to think about the people who you will administer either the trial or licensed vaccine to, so the volunteers who will come forward. And not only just think about the volunteers, you have to think about their families. So this person who is coming to offer themselves up as a volunteer in the study has a family around them, has a community around them. So when you're thinking about engaging and developing engagement materials, communication materials, it's not only just targeted at the volunteer. It's really engagement approaches and materials that will go out to the population around that particular individual. The other key people that you have to think about are the policymakers. the broader population. And I haven't put it here, but also very important is the regulatory bodies. You will remember from the slide on the failed Ghana Ebola trial, the mistrust and hesitancy and the fear and the misconceptions were around, or were in the community, amongst healthcare workers, regulatory bodies, so all the way from the community to the top, policy makers at the Ministry of Health in Ghana, all had misconceptions and mistrust on the vaccine. And so it is very important to think about the entire pathway, right from the individual who will take up the vaccine, and the ecosystem or the population that is around that particular individual. So some of the things that help us, sorry, let me just be sure that this is yes. Some of the things that we have set up as an institution, this is something that you can borrow for purposes of research trials, but this can also be applicable when you are just planning a vaccine, an activity around a vaccination. So it's really thinking about the proposal, and that's where we start from, the proposal and what the investigator or the project owner is intending to do, and thinking through how will you engage, and including this engagement as a section in your proposal or your protocol, if you're talking about a research study or a vaccine project that you want to undertake. You want to include in that document and begin to think about how are you going to engage, who are going to be the people, and what kind of documents or what kind of materials are you going to use. Very brief in the main proposal. One other thing that we also do is for clinical trials and also other studies that we do, we look at the informed consent documents to look at the language that has been used, because when you begin the engagement starts with, even at the point when you're recruiting that individual, you will have engaged them prior to now administering the informed consent. Maybe they'll have heard about the vaccine trial in a radio program or in a large community meeting in the population. But at the point when you are consenting, that is a form of engagement. And so we want to be sure that the language actually passes on appropriate information, because that individual who is participating in the vaccine trial will also become a source of correct or incorrect information to the broader community where they are coming from. And so it's important for them as individuals, as participants, as volunteers, to have accurate information. So we review the language in consent documents, and we also translate it to Swahili or vernacular, also to aid in passing on correct information about the vaccine trial. And once the proposal has been approved, then we sit and plan engagement, how we will do the engagement, how will we implement it, how will we document it, and how are we going to close out the vaccine trial once it is completed. And while we are doing this, we also link up with our colleagues in the communications department within the research program. So we work together as an engagement platform. We work very closely with the communications department within the research program, and we sit together in some of the planning meetings to be able to ensure that we have captured all the appropriate stakeholders that we need to engage. So I've just picked the last rectangle and brought it into the next slide to be able to expound on what I mean by planning, implementing, documenting, and exit. So we have an approach or a mechanism that we call a CAST. CAST is Community Engagement Advice for Study Teams. We call it community engagement. So community engagement is a loose term that we use to include even stakeholders. So when we say community engagement, I'm not only just meaning the local community. I'm including the Ministry of Health and other stakeholders like policymakers in that. So we normally hold these meetings to discuss where, for example, the study team, the principal investigators will tell us all about the vaccine trial, where it is happening, the population that is going to be recruited into the vaccine trials. Is it children? Is it adults? Is it a combination of both? What are the study procedures that this particular trial is going to use? We also discuss sensitivities, whether there are any sensitivities in any of the procedures that are going to be. And what I mean by sensitivities is considering the context where you are carrying out the vaccine project and the procedures. So some studies that we have undertaken, sometimes not necessarily a vaccine trial, but other clinical research work has taken samples, for example, hair samples, things that are new and would be deemed to be strange in that population. A study procedure that has not been undertaken in the past, that population is not used to that type of a study procedure, is what we would call a sensitive study procedure. And then we move ahead in that CAST meeting to discuss who then needs to know about this work, who needs to know about this study, or who needs to know about this project. If you're talking about a vaccine project, maybe it is not a research, it's not a piece of research work, it's just a vaccine project that is maybe an implementation piece of work. So who needs to know about that? And once you have mapped out the community, the partners, the stakeholders that need to know, you also need to have an understanding of their interest, their influence, and their power. You need to understand that because from our experience, we have learned that those interests and the influence can actually impact on how your vaccine trial or a vaccine project progresses on. Then we also discuss in this CAST meeting, we talk about how are we going to approach these stakeholders or communities that we have identified. What approaches are we going to deploy to be able to have conversations and interactions around this vaccine trial with the populations that we have identified. We also discuss key messages. Key messages are very important because once the key messages have been developed, those are the key messages that then will go to other study members, maybe community engagement practitioners that are working. So in our case, key messages that are given to engagement practitioners, but they can also be key messages that are passed on to all the staff in the research program, because our staff also interact with the population out there, be they the regular community members, be they healthcare workers. In our setting in Kilifi here, we are within a hospital and we carry out a lot of research within the local referral hospital here in Kilifi. So these are key messages that can aid in passing on correct and consistent messages about that vaccine trial or vaccine project. You don't want people making up answers in their heads when they are asked a question about the vaccine work that is going on. And so developing like a one-pager, simple bulleted document is very helpful in terms of passing on correct information. As I've said, and as you've seen in the previous slides, mistrust is really one of the main drivers of hesitancy. And so when you have messages that are consistent, one a staff member is giving the same message, another staff member is asked and is giving the same message, that can help to build some of the trust. And then in these meetings, we also discuss timelines, engagement timelines versus study timelines, because in our context, in our setting, we are carrying out research. And so we want to ensure that the timelines for the engagement activities and the study timeline are complementing one another, such that the engagement activities are not causing study timelines to delay. So I've talked about mapping. This is a very busy slide. And I've put it here deliberately to give a flavor or to give an example of when we were planning for our vaccine, COVID-19 vaccine trial, the AstraZeneca vaccine trial. We did map out our, our stakeholders, and we realized that we had internal stakeholders, and the internal stakeholders were stakeholders within our own research program, the principal investigator, Director General KEMRI, that is Kenya Medical Research Institute, then the director within the center here where we are, study team members, engagement staff, all the staff within the research program, corporate affairs. So we did map out our own internal audience that needed engagement. And then we had a whole load of external, you will find that the external also has KEMRI-Wellcome Trust Research Program staff, because they are considered both internal and external. External because we do have staff that work and live in the population, and their workstations are out in the population. And so this type of mapping then enables you to get a clear picture of who do you need to engage and who is engaging with who, so that then there are no overlaps. I've put some colored filling in some of the boxes of really critical groups of people. So the local community was very important for us, because that is where we were going to draw some of the study participants, local Department of Health, Ministry of Health, because some of the very initial study participants were drawn from the health workforce. And so we needed to engage the local Department of Health, because we were drawing study participants from our local hospital here, as well as peripheral primary healthcare facilities like dispensaries and health centers, and more broadly, just members of the Department of Health, as well as the Ministry of Health. And so we needed to engage that particular group. You will see that local assembly, which is in Kenya, we have devolved government systems. So we have a national assembly and we have a local county assembly. So these are politicians. You'll see that I've also shaded those, because especially during the COVID-19 pandemic, politicians had a keen interest on what was going on in their populations. The other green shading is a community advisory board. We worked very closely with the community advisory board to get their input into how exactly their recommendations were, how exactly they felt we should actually engage the broader population, giving us some insights into some of the questions that could come from community members that then we needed to prepare for and include in our key messages documents. Then the media, really very, very important. The media during the COVID-19 pandemic was a big culprit of spreading misinformation. And so during our vaccine trials, we really engaged the media quite a bit to be able to ensure that the vaccine trial had the appropriate covering within the media or from the media. So some of the issues that were raised, so some of the methods of engaging I've sort of like already alluded to, and then in the slide where I was showing some examples of community and stakeholder engagement, that slide that had the CAB, the schools, the radio program. So those are some of the approaches that we used to engage the population. While we were engaging and as we were going through the process of engagement, there were some things that were recurring. There were some concerns, issues, questions that were being raised that were recurring, cutting across all the engagements, and some of them are what I'm indicating here. So some of the questions were around the why vaccines are even necessary, people feeling like perhaps, we don't actually need vaccines. The human body is made to take care of itself. There were questions around, how vaccines are made, how vaccines are manufactured. There were questions about the COVID-19 vaccines and how that particular vaccine had been made. And it's linked to the very last bullet there, and I'll explain that. And there were questions around why vaccine trials are only, so perceptions of the fact that, or not a fact, but perceptions of vaccine trials just being done on Africans or in populations around low and middle income countries. So that is something that we demystified during our engagements for the COVID-19 vaccine trials. There were issues around, populations, community members feeling like vaccines are not needed, and that we need to go back to our traditional health systems and what we used to do to take care of ourselves when diseases would emerge in the population in the olden days. And there were questions around side effects of vaccines. Obviously, the issue of blood clotting is still with us till to date. Lots of fear around that, the fact that there were some blood clots that were identified in some of the populations vaccinated in high-income countries. Issues raised around whether vaccines are being made to actually reduce the population, whether vaccines are being made to cause women and girls to be infertile. So a lot of issues around that. And then concerns around why there's no vaccine for HIV yet. So this is linked to the bullet that I've said, where, how was the vaccine made and where was the vaccine done? And that, people have had questions around why is it that the COVID-19 vaccine was made very, very fast, and yet HIV, which is also a viral disease, has no vaccine to date. So these issues, as they were coming out during the engagements, especially for the COVID-19 vaccine trials, gave birth now to, or they caused us now to develop a video, a short video to explain why vaccines are important, a short video that explained how the COVID-19 vaccine was manufactured. And the video also explained the process from the development of a vaccine, who authorizes it, which kind of people look at the product before it can actually be administered on populations. And we developed this video with an aim of using that video then to build understanding on vaccines and the vaccine development process. I'll play that video right at the end, and it's 8 minutes. This is my last talking slide, and then I'll play the video. Some of the lessons that we've learned as we have implemented vaccine trials is that the relationships are very important. The more community members feel that you're developing a respectful relationship, you listen to their concerns and you respond to their concerns genuinely, that can help to build the trust. We've put in a lot of effort to ensure that our engagement is not just a tick box, but that it is genuine, that we are genuinely forming relationships and listening to the populations, partners that we work with in the vaccine ecosystem. The engagement has to be continuous. It can't just be a one-off activity. You have to really develop a plan that has a beginning and has a continuation all the way to the end of the vaccine trial or vaccine project that you're implementing. And then once the project has ended, people want to know what has been learned. Has the project been effective? Has the trial been effective? Have you been able to get an answer? Even a negative answer is an answer. So people still want to know, even where you've done a vaccine trial and it has shown that that vaccine is not efficacious, that still people want to know that. So it's very important to disseminate learnings from or findings from the trial that you have undertaken. The rising infodemic is a threat and will continue to be a threat. And so we have to be a step or several steps ahead of it by ensuring that we are ready to have conversations with the population, with stakeholders, give them enough information that then will help them support the work, the vaccine work that is being planned and being undertaken. Finally, the fact that engagement, community, public, police engagement, all of those, they really require skill, they require skills, they require experience. And so you need to be able to identify, as I've already said, local groups and individuals who will be able to partner with you and work with you in building these relationships and building this trust. So I'll stop there, and I will, I can't now remember whether I shared with sound. Clive, you'll tell me whether that sound is on or not.
Yes, I will.
Okay. Is there sound?
Yes.
Okay, excellent.
The KEMRI-Wellcome Trust Research Program is based in Kenya under the Ministry of Health and brings together leading scientists from Kenya, from Africa, and from around the world. Our work has contributed to improved health through the development and evaluation of ways to treat and prevent diseases like malaria, yellow fever, pneumonia, and Ebola. KEMRI's research is informed and supported by community stakeholder engagement. This engagement, combined with meeting national and international guidelines, ensures that our work meets the highest ethical standards. Given the current COVID-19 pandemic, it is essential that Kenyan researchers play a prominent role in addressing one of the greatest health challenges of our time. Researchers from KEMRI-Wellcome Trust Research Program are currently collaborating with researchers from the UK to evaluate a new vaccine called ChAdOx1 nCoV-19. So, how will this vaccine work, and how will researchers evaluate it to see if it gives protection? People who have never had COVID-19 can easily become infected themselves if they come into close contact with a person who has the disease. This is because they have no natural immunity or defense to protect them against infection. Being infected may enable the body to build natural immunity, which may prevent a second infection. Vaccines mimic this. When a person is vaccinated, the vaccine stimulates the body to produce an immune response or a defense against infection. A tremendous amount of lab work is needed to develop a vaccine, and this can take many years. From the initial lab work, trial vaccines are first tested on animals, and if safe, they proceed through different stages of clinical trials with people. Initially, trials with relatively small numbers of volunteers are done to see how the body's defense responds to the vaccine and to confirm the vaccine's safety. Then, trials are done with larger numbers of volunteers to see whether they give protection against disease. When there is strong, carefully reviewed evidence of protection, regulatory bodies give permission for the vaccines to be rolled out to larger populations, but the vaccines are still monitored. Before any health research can be done with people in Kenya, the research must be carefully reviewed and approved by local, national, and international scientific and ethical committees. These committees check that the scientific plan is strong and that the risks to participants are minimized and that their rights are guarded. So, let's have a closer look at how the new ChAdOx1 trial vaccine is made. This is a picture of an adenovirus which causes a mild flu amongst chimpanzees. It can be used to deliver the vaccine into the human body, but first the adenovirus is modified so that it cannot cause any disease in humans. Then researchers carefully extract a component of genetic material from a COVID-19 virus and insert it into the genetic material of the adenovirus. This specific component stimulates the human body's immune response. More of this modified adenovirus is made so that a vaccine can be prepared. A similar approach was used to make the Ebola vaccine that controlled the epidemic in West Africa. The approach is also used in development of vaccines for other diseases of public health importance in Africa and Europe. We want to find out whether this approach can be used in the new vaccine to protect people from COVID-19 infection. To do this, researchers need to compare the group receiving the ChAdOx1 trial vaccine with a control group. Control groups enable researchers to compare how well the vaccine works against a substance which does not offer any protection at all against COVID-19. In this trial, rabies vaccine is used as a control. We know that rabies vaccine doesn't protect against COVID-19, but it will give participants protection against rabies as a benefit for taking part in the trial. 40 volunteers will take part in the trial for the first month. This will enable researchers to confirm the safety of ChAdOx1. The study will be explained to them, and if they are healthy and willing to participate, they will sign a consent form. Each of 40 participants is given either the ChAdOx1 vaccine or the control, in this case rabies, and this is decided randomly or by chance, a bit like flipping a coin. But participants will not know whether they have been given the ChAdOx vaccine or whether they were given the control. This is to make sure that their behavior is not influenced by the type of vaccine given to them. Participants will be followed up to closely monitor their health, the safety of the vaccine, and whether participants experience vaccine reactions like mild fever, swelling, or itchiness around the site of the injection, and how the participants' bodies develop immunity in response to the vaccine. Because of the way it's made, the vaccine can't cause COVID-19 infection, but if a participant becomes infected through contact with an infected person in the community, then they will be treated according to the Ministry of Health guidelines. They will also be reminded to try to avoid infection through following government guidelines on hand washing and social distancing. When researchers are confident that the research can proceed, 360 new participants will be recruited. Again, chance will be used to decide the vaccine which participants are given. Half the participants will be given ChAdOx1 and the other half will receive the control. Over the next 12 months, all the participants, including the initial 40 volunteers, will be monitored and checked regularly. As new infections inevitably occur, researchers will be able to see whether the trial vaccine ChAdOx1 gives better protection than the control. Collaboration between research institutions across the world is essential to develop and assess globally acceptable health innovations, and Kenyan researchers are at the forefront of collaborative efforts to develop and evaluate a vaccine which may offer protection from COVID-19.
So that's the end of my presentation, Clive. Let me stop sharing.
Yes, thank you, Noni, for the informative presentation.
Yeah,
we
so
really
maybe I can
appreciate.
just, sorry, so maybe I can just give a brief of that particular video. So in this video, You will have seen that the video has talked about the organization, which is this organization that is carrying out this vaccine trial. Very important information. In addition to just sharing about the organization, you'll have seen the photos that have been shown in terms of how we do our engagement, emphasizing the fact that when we are carrying out a vaccine trial, we don't just get into the community and just start recruiting people. We give them time to understand what is. So we've seen pictures of engagement. What we are also, so this was a public engagement tool. The video was meant to be a public engagement tool. And so we've also shown our labs, emphasizing on the capacity. When you see the labs, they're very well equipped. So just demonstrating that we actually have the capacity to carry out this vaccine trial. And then you've seen in the video, we are talking about why vaccines are needed, how they work in terms of how they generate immunity in the body, and then how the AstraZeneca vaccine itself was made, and then who authorizes by the time a vaccine is being, a vaccine trial is being undertaken, who has authorized it. So we tried to cover a lot of the questions that you will have seen came out in some of the engagements, that we did. So thanks. Yeah, I think I'll stop there. Back to you, Clive. Sorry.
Yes, thank you for the informative presentation. We really appreciate for your time. Maybe we'll take a few questions from the audience. You can use the icon, raise your hand, and then we'll give you the microphone. Ask the question. Yes, there's a Sakari. Yes, Zakaria. Please go ahead.
Okay, thank you. Thank you for that very elaborate presentation, and I can clearly see that the work that is going on at Kilifi is really impressive, and I hope to visit very soon. So I'm Zakaria Kafuko. I'm the director for One Day Africa, which is a public health nonprofit. Our work focuses a lot around promoting clinical trials, especially in Africa for infectious diseases. We also are maybe popularly known for advocacy around controlled human infection models, and especially their utilization towards maybe down selecting or de-risking some of the models for clinical trial, studies, especially in locations where resources are limited, like in Africa. So maybe building off of that, maybe just a little bit curious to understand from you, Noni, to what extent would you say the clinical trial volunteers are involved in the design of the trials that you undertake at Kilifi? So like maybe from the beginning, or to what extent into the entire timeline of the development are they involved? Thank you.
All right. Thanks. Clive, do you want me to answer each question or take a couple?
Yes, go
Okay.
ahead. Sure.
Okay, fine. So thank you very much, Zakaria. So yes, obviously, when you're thinking about the different types of research, there are clinical trials or clinical research work that can be actually set in a certain way, such that it's not possible to change some of the things that have been included in the procedures, for example. However, for us as a research program, as you'll have seen in the presentation, we have established community and stakeholder engagement now going to almost 2 decades. We have learned lessons, obviously, throughout all of that. And more recently, in the last about 5, 6, 7 years going backwards, we have actually made concerted efforts to ensure that when we are planning our studies, we involve the populations where we are going to draw study participants from, be they the Department of Health. So for example, for the COVID-19 vaccine trial, before the protocol was approved by the regulatory bodies, we had to present that work to the Department of Health. They didn't have much input in terms of the scientific procedures, but obviously they gave input in terms of how they felt perhaps we can engage better, what kind of methods, what kind of approaches to use to be able to get people. And that engagement also helped to demystify some of the misinformation that they too had. It's interesting that you've talked about controlled human infection studies, because I'm sure you will already know that we undertake those. And for some of those human infection studies, we have actually engaged our community advisory board members, and we have asked them questions around, first of all, whether the study is acceptable or not. We have asked questions around the procedures and what they think about the procedures, including inpatient stay, inconveniences, how they think study participants should be compensated. In one particular human infection study, which includes also a trial within it, we had identified a facility where we were going to put the inpatient volunteers, and the community advisory board members didn't like that particular facility, and so we had to change and identified a facility that the community members or the CAB members felt will be much closer to the volunteers in terms of proximity to where they're being drawn from in terms of their homes. We have, even when a clinical trial has begun, as is the case, for example, of some of the human infection studies we have undertaken, we've learned lessons during the engagement that have then informed some of the procedures. So for example, lessons related to how research participants understand the procedures. When we started our human infection studies, we at some point we introduced visuals during consenting, because during the engagements, we were learning that while the participants understood the procedures, they understood everything that was going to be done to them, when the study actually began and they started actually experiencing the study procedures, then they came up with suggestions. So one of the things that they pointed out, for example, was the volume of blood that they didn't quite understand the volume, and so during our engagements and consenting, we introduced visuals in terms of demonstrating how much blood actually will be taken by showing them visually, not with blood, but of course, like with water. So yes, we have, to answer your question, we have, tried to ensure that during our engagement, we include the voices of the study participants, potential study participants who are the communities, in the processes in terms of them inputting into the study procedures. I hope that has answered you, Zakaria.
Thank you so much. Thank you.
Thank you. We have a few minutes also for more questions from the audience.
I get very worried when people are quiet. Either they completely didn't understand or something.
Let's give them a few minutes. Yes, there is hand two actually. Yes, Dennis.
Okay, thank you very much for such a wonderful talk. Very informative one. I'm Dennis James. Yes, early career upcoming, vaccine research enthusiast. Yeah. So my question, I just get an inquiry in terms of sometimes back towards the start of the year, KEMRI-Wellcome Trust roll a course on vaccinology for some young aspiring scientists, not only young people but just for everyone, an introductory one. So just a follow up to that is when I'm curious to know when will whether the program is looking forward to rolling such kind of a program for people to learn, because I have colleagues, including myself, also interested in rolling out to such kind of a course or other program. Yeah, thank you.
Okay, I think I'll let Clive respond to that, or
Yes.
I see Caroline. I don't know whether Caroline has any information, but maybe Clive can respond for us. That's more for
Yeah.
Clive than me.
Yes, actually, through the Vaccine Workforce Development Program, we have an annual vaccinology course. Last we did it in Senegal, which was a bilingual course. So it's an annual course that rolls out. So be on the lookout for more opportunities. We also have apprenticeships, more like internships in vaccine manufacturing companies or industries. And then we have the webinars like what we have. So be on the lookout for the opportunities. Definitely will advertise them whenever they arise. We have another question from Kelvin. Yes, Kelvin.
Kelvin, you're muted. Okay.
Sorry, I was struggling to unmute. Thanks, Noni, for such a wonderful presentation. I'm Kelvin Cott I work for KEMRI-CGHR, and I also deal with community engagement. We are implementing some mortality studies in Western Kenya, and yes, we've had to do a lot of community engagement now that we are taking sensitive samples. When I call them sensitive, I mean somebody has passed on and you want to draw samples from them, which has been challenging, but we are faring on. My question goes that with the dwindling finances, I wonder how you people are able to conduct such a robust engagement. We are also suffering from the same dwindling environment, and where when the resources become few, then the community engagement becomes like the first casualty. I wonder how you people are managing that.
Thank you very much, Kelvin. It's good to have a question from a colleague in the same organization. That's a really, really important question. It's something which we may not have been thinking about previously, but obviously right now it's really at a priority in terms of planning our engagement. At the moment, all of our engagement, so the KEMRI-Wellcome program, you will know we are funded by Wellcome Trust, and so Wellcome Trust funds our core platforms, which includes the community engagement. Aside from that, we encourage researchers to include community engagement, community stakeholder, public engagement, whichever you want to call it, funds as they write their proposals. So we have been able to do what we have done with the funding that Wellcome has been giving us. Aside from that, and if that was to go away, we would still be required to do engagement. And so one of the things that we encourage researchers is within your budget, you need to budget, as you budget for a field worker, as you budget for a communications person, as you budget for all these stuff that you need, it's important to also budget for an engagement staff. Aside from that, some of the other things that we are looking forward to doing, and we have piloted a little bit, and we felt that it actually worked, is conducting trainings. So one of the things that we are doing is training journalists. So working with journalists and ensuring that even when we building that mass of journalists that understand research and are able to report appropriately, and can also support engaging the broader public. So when we are doing a radio program, we have journalists now who can run a radio show talking about research. In fact, even without us, supporting them in any way, because we've done quite a bit of capacity building in terms of training journalists to understand research and be able to support public engagement with the broader population. So I would imagine that that bit would be able to continue because we have journalists that have been working with us for quite a while. We have partnered with local groups. One local group that we partnered with, we trained them on research. We brought them to the research program, spent 3 days very initially with us as a research institute, went to the lab, interacted with scientists, and then we brought them on board for about 1.5 years, close to 2 years, working with us, engaging the community on research. So that gave us an indication that we can actually work with local groups and empower them to be able to understand sensitive, because engaging for research is a little bit different from the community engagement for implementation, like a health promotion program where you want community members to take up nets or something like that. It's a bit different. There's ethics that surround engaging for health research, or rather community engagement for research has ethical underpinnings. And so when you want to hand over the engagement aspects to another party, they have to be really well trained. So that particular group worked with us. When they completed their contract with us, they actually won another contract with the Kenya Marine Fisheries Research Institute, and they carried out some engagement work for that particular research institute. And I can see, I've heard and I've seen on their social media platforms that they have worked with a couple of scientists, international scientists who have undertaken research work in Mombasa, for example. So we are not yet there, but it is possible to build capacity of local groups so that there are local organizations that can continue on the engagement even beyond funders pulling out. Hopefully that will not happen in terms of funders pulling out. But of course, we want to build capacity, yes. I hope that answers you, Kelvin.
Thank you for such a elaborative answer. Dennis James, is still your hand is up. Can you go ahead? Yes, Dennis.
Maybe it's an old hand.
Maybe. Okay, Esther Marona.
Hi, can you hear me?
Yes, we can.
Yes.
So much for organizing such an webinar. I'm looking forward to more of such. Mine is more of a concern. Are we thinking of doing such on maybe HIV vaccines and the likes of
sorry, Esther, you're not coming through very clearly. I don't know whether it's just me, Clive, or I don't know if
yes,
you can hear.
there is an echo in the background.
You can't hear me?
Yeah, no, it's
we can, but
okay.
You can try again.
Okay, I'm saying I'm so grateful for organizing such an informative webinar. Mine is more of a concern. Are we looking forward to maybe researching on HIV vaccines and rolling it out as part of the Africa vaccine manufacturing process? And definitely, I'm looking forward to more of such webinars. Thank you.
Very, very interesting question. I don't know whether I can answer that effectively. We have, I think, undertaken one here within KEMRI-Wellcome. I think we've undertaken one HIV vaccine trial. I'm trying to remember. Yeah, I think towards the tail end of just before Ed Sanders left. So there are a couple of HIV trials that are being undertaken by various institutions. Within KEMRI-Wellcome, we did one. I'm not very sure whether it has ended. I think it could have ended. But you know, there are possibilities. I mean, other parts of Africa, people like South Africa has a lot of HIV vaccine trials that are some have ended, learned lessons, and you know, new trials are being planned to start. But I can't effectively answer that. It needs to be answered by a researcher who is actually working on HIV vaccines, which I'm not.
Yes, as he requested that we'll have more webinars and we'll try to include a researcher who works on HIV vaccines like Ntumbi Ndungu, from South Africa. Sure.
Yeah,
yes, and we'll keep advertising these webinars. So be on the lookout for such. Yes, time is not on our side. Maybe Noni, you could make last remarks from.
Thank you, Clive, for inviting me, for having me. Just emphasizing the fact that this Vaccinology webinar series and the whole Vaccinology program that we are running is just to support building that vaccine ecosystem within Africa, because we are moving, as I've said, we already have manufacturers within Africa, but the challenges can potentially remain the same, where you have local vaccines being manufactured locally here, but the population still does not trust. So community engagement is very important. For very many years now, populations have been saying we need to be involved in the things that you're planning for us. They could be beneficial to us, but if you don't explain them to us appropriately, then we will not partake of those you know, products or interventions that you want us to partake of. So it's really, really important as researchers to be very intentional in how we build relationships with the communities, with our stakeholders, all levels of stakeholders, to be able to implement successful projects in our populations. So thank you so much, Clive. Mwana Juma, I've seen your comment, and well taken, and thank you for pointing that out. Back to you, Clive. Thank you so much.
Yes, thank you, Noni. Thank you for the informative presentation and handling the Q&A session. And thank you very much to everyone in this webinar. We would like to hear about your experiences and what else you would like us to discuss in upcoming forums. Before we close, kindly requesting that you take a few minutes to respond to the post-webinar survey posted in the chat. There is a link for that survey. Thank you. Have a very good day and looking forward to more engagements with you. Appreciated.
Thanks, and bye, everyone.